Assalamu alaikum wa rahmatullah. Today we are going to explain Introduction to General Pathology and first part of cell injury. By the end of this lecture, you are going to define pathology, identify and list the aspects of pathology, identify and list the different responses of cells to injury, list the types of adaptation, define types of adaptation, identify their causes, and describe their pathological features. What is pathology? Pathology is the study of suffering or is the study of disease. So pathology means this is the study or science of disease. Is it important to study pathology? Yes or no? Of course, it is important. Why? Because pathology means that you are going to identify the disease and so you can treat the disease. If you don't identify the disease, you cannot treat the patients. This is the tree of medicine. These are the branches of specialization. Ophthalmology, dermatology, psychiatry, neurology, surgery, pediatrics, obstetrics, gynecology, dentistry, internal medicine, and so on. These are the clinical branches. And we have the foundation. And the foundation is the root of the tree. The root of the tree shows these foundation subjects or basic science: anatomy, embryology, pharmacology, physiology, microbiology, cell biology, histology, chemistry, physics, genetics. All these are the normal foundations and the normal subjects of the normal human being. What is the bridging subject between the foundation and the tree of medicine, the clinical branches? This bridging subject is the pathology. And this pathology means the study of the disease. You pass from the normal to the abnormal through the pathology. And if you study the pathology, you can understand all these clinical branches later on. The pathology is again divided into two main cores. The general pathology, which is the main trunk here, and this means the specific changes that occur at the level of the cell and the tissue. And then we are going to study the systemic pathology, and in this we are going to study the specific diseases in different systems like cardiovascular system, GIT, gastrointestinal system, CNS, central nervous system, and so on. In the future, what are you going to be? I think you are going to be doctors, nice doctors, male doctor and female doctor. And what does the doctor do? What are you going to do? You are going to manage or treat the disease. So the patient comes to you suffering from a certain disease, and you are going to treat him and treat her. So you are going to manage or treat the disease. But to manage or treat the disease, you need to diagnose the disease at first. So you need to know which type of disease is affecting a certain patient. Okay? To diagnose this disease, you need to do things. At first, you need to talk to the patient, taking history to know what is the complaint, how long was this complaint, and so on. And then you put the patient under examination. You examine the patient, you measure his blood pressure, you palpate the organs, palpate the liver, for example, to see if this liver is painful, if this liver is enlarged, if this liver is soft or hard, and so on. So you examine the patient to collect data from history and examination. Then you order for laboratory and radiological investigations to complete the pieces of puzzle. Of course, you don't just go and ask for any laboratory or radiological investigation. You are going to ask for specific investigations depending on the data that you collected from taking history and doing examination to the patient. So you just collect the pieces of puzzle to diagnose a certain disease, and then you can manage the disease. So you need to know a lot about any disease in order to diagnose this disease. So, in order to know what about a certain disease, you have to know a lot about each disease. At first, if you have a disease here, what do you need to know? At first, you need to know what is the cause of this disease. This cause may be microbe, maybe trauma, maybe chemical reaction, or whatever. So you need to know the cause of the disease. This cause leads to this disease by a certain what? A certain mechanism. So the cause causes the disease by a certain mechanism. Mechanism means the process. Okay, the process in which this cause lead to that disease. This process or mechanism is called pathogenesis. So what is pathogenesis? Pathogenesis is the mechanism by which a certain cause led to the disease. Fine? Is it important to know the pathogenesis? Of course. If you can reverse the pathogenesis, you can treat the disease. So it is important to know the pathogenesis. After you know the cause, and then you know the pathogenesis, you know after this cause led to the disease by a certain mechanism, it will lead to changes. What are the changes? Changes mean that you have something that changes from normal. These changes are called pathological changes. And these pathological changes can be in the normal anatomy, okay, of an organ, and can be in the normal histology of the organ. If the change is in the anatomy, it is called gross pathological change. You can see it by the naked eye. So you can see a change in the liver, for example. If this is a liver, you can find enlargement, you can find shrinkage, you can find some cavity inside the liver. So this is change in the normal anatomy. You can find the change in the histology if you go and do a section, okay, take this and process this section, paraffin block, embedding and so on, and you cut it on a slide, glass slide, and see it by histology. You can find some abnormality in the hepatocytes, for example. Here, hepatocytes, they show some changes at the level of the histology. They can collect anything inside, they can be lost, they can be enlarged, or can be changed, and so on. And this is called histopathology or microscopic change. Okay, so we have a cause, we have pathogenesis or changes in the histopathology. Fine. And so in pathology, you just go and identify, learn a lot about diseases. What do you learn about the disease? You learn the etiology or the cause of the disease. You learn the pathogenesis or the mechanism of the disease. Why are these two important? They are very important for the diagnosis, and they are very important in treatment. Why? Because you treat the etiology. If you have a microbe, you give antimicrobial agent. If you know the pathogenesis or the mechanism, you are going to give drugs, and this is given in pharmacology. And so you reverse the mechanism to treat a certain disease. Then you know or you learn the pathological changes, which are the gross and microscopic changes. Why? Because they help you a lot in the diagnosis of the disease. You diagnose by palpation, radiological examination, and so you identify changes in the gross, even by
just examination of the patient or radiological investigation. And you know the microscopic changes, okay, by a biopsy taken from you can take a part of the organ by a needle or by excision or by incisional biopsy and so on, and this biopsy can be taken from the organ to be treated like histology and identify histopathological changes and help in the diagnosis of the disease. So pathological changes are very important in the diagnosis. Okay, what helps you more in the diagnosis? The clinical manifestations of the disease. These are the clinical picture of the disease in the form of signs and symptoms. Symptoms are the symptoms given by the patient. The patient says, I have pain in something, I have a headache, I have inability to move my limb, and so on. This is the symptom. And the signs are the clinical manifestations you identify during examination. These are not given by the patient. So you have the symptoms given by the patient, you have the signs you identify by patient examination. And so the clinical picture is very important in the diagnosis. Okay, the clinical picture is very important in the diagnosis. If you just go and diagnose a disease by knowing the etiology, pathological changes, manifestations of the disease, you have something important. You need to know what are the complications of such a disease and what is the fate of the disease. Progression and outcomes. You need to know the fate of each disease and complications. Why? If you know the complications, you are going to think about these complications. You have a patient at hospital and you don't know he has a certain disease and you don't know the complications. If you have the complications, you are not going to identify or anticipate or prevent the complications. But if you know the complications of each disease, you have the possibility to prevent such complications and identify them early when they develop. Okay, because complications are complications, so they make everything worse. If you prevent or avoid complications, it will be much better. Knowing the fate of the disease is very important also. Fate, is this disease going to be a chronic disease? It will last for a long time. Does this disease kill the patient, like cancer or something like that? Or not all cancers kill the patient? Fine. So you have to know the fate of the disease for many reasons. First, you have to know the fate to identify the proper treatment of a patient, and you have to identify what to say to the patient and his faults. They are going to ask about the fate of each disease for their own patient. Okay, so in the pathology aspects, you learn a lot about the diseases, you learn the etiology, you learn the pathogenesis, you learn the pathological changes, you learn the manifestations of the disease. In short, a lot will be taught about the clinical branches later on, but you are going to start to know this clinical picture from pathology here, and you need to know the progression and outcomes, which are the fate and complications of each disease. Fine. What are the chapters you are going to deal with in the general pathology? In the general pathology, you have general changes, okay, that occur in different organs at the level of the cell and the tissue. We have items in general pathology, starting with cell injury. Injury means you have injury, cell exposed to injury, whatever is the injury, so you have to identify the changes that occur in the cells as they are exposed to different injurious stimuli. Okay, so this is the cell injury. After the cell injury occurs, you have reaction. So reaction of the body to injurious stimuli is called inflammation. So inflammation is a reaction to cell injury. So first we are going to study cell injury, and then we are going to study inflammation, which is the reaction of the body to cell injury. Then with cell injury and inflammation, you have some damage occurring in the tissues and organs. Okay, this damage is caused by cell injury and can be caused also by inflammation. Inflammation should clear the damage, okay, and after clearing the damaged cells and tissues, you have to repair. So you have to repair what is damaged by cell injury and removed by inflammation. You repair. You need to go back trying to hold things up and trying to repair the tissue again. So you have repair. This is the third chapter in general pathology. So you have cell injury, you have inflammation, which is reaction to clear the damage, and you have repair that repairs the damaged tissue. And then we are going to deal with some causes of cell injury like infections. Okay, we are going to deal with the immunologic disorders that can cause cell injury, and hemodynamic disorders, okay, changes in the blood supply of an organ that can lead to cell injury. So these are the causes of cell injury we are going to learn in general pathology. And lastly, in the general pathology, you are going to learn neoplasia. Neoplasia is new growth or tumors. So you are going to learn everything about tumors, or this is the new growth. Okay, so these are the chapters of the general pathology you are going to learn. Fine. Cell injury. This was a man that was walking and singing, and suddenly he had something, okay, that led to trauma to his scalp here. Okay, so this patient was singing, walking and singing, and then he suddenly had trauma to his head like that. Okay, look at this. What happened to this man after exposure to this trauma? At first he stopped singing, okay, and he stopped walking, so he stopped doing a function. He was doing something and then he stopped doing this. At the same time, look at his scalp here. You can find there is some indentation, okay? There is something caused by this trauma. So you have something that can be seen here. You have something morphology. You can see by your eye. There is a change in the morphology and there is change in the function, okay? And this is the definition of cell injury. So cell injury means morphological or functional changes, or both, that can occur in a cell as a result of stress the cell encounters. This stress can result from changes in the internal or external cell environment. So this is simply the definition of cell injury. It is the morphological or functional changes, or both, that occur in the cell as a result of stresses that the cell encounters. These stresses for a cell can come from changes inside the cell or outside the environment of the cell. So from coming from inside or outside the cell. The normal cell undergoes what's called homeostasis. If the normal cell is exposed to stress, first can it adapt. So adaptation اللي هو التكيف. Adaptation means that the cell can cope with the new change in the stress by doing some changes in the cell. This is called adaptation, and we have a lot of physiological adaptation. But if to happen, the cell would undergo cell injury. So the normal cell exposed to a stress can undergo first adaptation if it can adapt. If it cannot adapt, or it has a strong injurious stimulus, it will undergo cell injury. So I'm going to have injury to the cell. This injury can be mild or transient injury, mild and transient, and so it is reversible. And then I'll go back to normal condition. So if I have just mild or transient injury, because the injurious stimulus wasn't very strong and it didn't last for a long time, and so I'm going to go back to the normal. This is called reversible injury. It is reversed to normal. But if the injurious stimulus is severe and progressive, okay, it is severe and it lasts for a long time, progressive, and so the cell cannot reverse to normal, so I'm going to have irreversible injury. Irreversible injury to the cell means cell death. So I'm going to have cell death. This cell death can occur by two ways. One way is called necrosis, and this is the homicide of the cell, necrosis, or it can kill itself by apoptosis, which is suicide. Okay? In both they are cell death, but they are different in the mechanism, different in the causes, and different in the morphology. Fine? So, in this diagram, we identify the changes that can occur in a normal cell when it is exposed to a stress. First, it can undergo adaptation if it can adapt and the stress is not very strong. If it cannot adapt or the injurious stimulus is stronger than this ability, I'm going to have cell injury. This cell injury can be reversible injury or irreversible injury, depending on the injurious stimulus. If it is mild and transient, so I'm going to have reversible injury and I'm going to go back to normal if it's of cell death. So these are the topics we are going to learn in cell injury. First, adaptation, then we have cell injury in the form of reversible injury and irreversible injury in the form of necrosis and apoptosis. Fine? These are the points we are going to clear in the cell injury. Start with this match. In A, you have two legs, and this patient has what is called poliomyelitis. poliomyelitis اللي هو شلل الأطفال. This is paralysis occurring in children due to viral infection. And in this you have athlete, okay, رياضي. Okay, this is an athlete person. Fine. If you look at both, you have changes in the muscle. Okay, you have changes in the muscle in this one, this leg, and you have changes in the muscle here. Match which has increase in muscle size or hypertrophy, A or B? Of course, in B, in this athletic person, you have increase in the muscle size, which is called hypertrophy. And in which has the decrease in muscle size or atrophy, اللي هو الضمور, this occurs in A, in poliomyelitis, of course. So in A, you have here you have decrease in the muscle size as compared to this one, and in A, you have increase in the muscle size. Decrease in the muscle size is called atrophy, increase in the muscle size is called hypertrophy. Atrophy and hypertrophy are forms of adaptation. Okay, so you have cellular adaptation. In cellular adaptation, we have reversible changes. Okay, they are reversible. If you reverse the stress, you are going to go back to normal. These are reversible changes in the number of the cell, in the size, in the phenotype of the cell, or the metabolic activity and function of the cell. So you have changes in the number, size, type, metabolic activity or function in response to changes in the environment. Okay, what are the adaptation? You know, we have atrophy, اللي هو الضمور, we have hypertrophy, which is the reversible of atrophy, we have hyperplasia, which is increase in the number of the cell, we have metaplasia, which is change in the type of the cell, phenotype. These are the 4 forms of cellular adaptation you are going to learn with us in cell injury chapter. Cellular adaptation can occur as response to physiological stimuli, as in response to hormones or endogenous chemical mediators, as in cases of enlargement of the pregnant uterus or a gravid uterus. And this pregnant uterus, it is markedly increased in size, and the muscle is markedly increased in thickness. Okay, and this is very important to hold the baby and to help in the delivery during contractions during delivery. And we have the adaptations in response to pathological stimuli, and then they are called pathological adaptations. So cellular adaptation can be physiological and can be pathological. Atrophy. Atrophy اللي هو الضمور. Atrophy is in the decrease in the size of a normally formed organ. After the normal development of an organ, it decreases in size. Okay? Due to what? Due to decrease in the size of the individual cells. So if the size of the individual cells is like that, they are decreased to this. So you have decrease in the size of the individual cells forming the organ, with or without decrease in the number. We may have decrease in the number of the cells also, plus decrease in their size. In both, we have eventually decrease in the size of a normally formed organ. We have something called ablasia, and in ablasia, you have failure of development of an organ. Okay, failure of development of an organ. It doesn't reach the normal size from first, and this is not atrophy. Okay, this is not called atrophy. And we have something called agenesis. This is absence of the organ. It's not present from the start, and again, this is not atrophy. So atrophy, you have a normally formed organ that undergoes decrease in the size, and this is totally different from ablasia and agenesis, and these result from either failure of development of an organ or even total absence of an organ. What are the causes of atrophy? We have a very long list. We have physiological causes and we have pathological causes. In the physiological causes of atrophy, if you think like that, you have atrophy of the lymphoid tissues at the thymus and appendix, and this is physiological. You have atrophy of the gonads after menopause. Gonads, you have atrophy of the uterus, you have atrophy of the breasts after menopause. You have aging, and we have senile atrophy of the heart and brain in very old persons. Okay, and this is a kind of physiologic atrophy occurring in all persons. We have a long list of pathological causes of atrophy. In pathological causes, we have first disuse atrophy. Disuse means what? You have the muscle is going to be fine and in the normal size if it is used. If you have disuse, it is not used, as during immobilization of a limb, as in cases of fracture, for example. If you have fracture and you have a cast surrounding a certain limb for 2 months or something like that, this will lead to immobilization of the limb, and this will lead to decreased workload of the muscle and leading to disuse atrophy. So when you remove the cast, you are going to find that this limb is smaller than the other one because atrophy occurred in the muscle. Of course, after reusing the limb, it will go back to normal again because it is a reversible change here. We have neuropathic atrophy due to loss of innervation, as in cases of poliomyelitis, شلل الأطفال, hemiplegia or paraplegia اللي هو الشلل النصفي. Hemiplegia occurring in if this is a person, okay, hemiplegia occurring in half like that. This part is paralyzed, or paraplegia occurs in the lower limbs only, like that. This is called paraplegia. In poliomyelitis, which is a viral infection and paralysis of the muscle of a limb due to viral infection, in case of hemiplegia or paraplegia, in all kinds of paralysis, I have loss of innervation. I have loss of innervation to the muscle, and this loss of innervation will lead to atrophy of the muscle. So neuropathic atrophy occurring due to loss of innervation. We have endocrine atrophy as in case of hypopituitarism. Of course, in physiology, you studied the endocrine axis, and you know that the pituitary gland, okay, is controlling other endocrine organs like thyroid gland, like suprarrenal gland, like the ovaries and testes, and so on. So the pituitary leads the other endocrine glands by hormones. If I have hypopituitarism due to some damage occurring in the pituitary, so I don't have the hormones that were secreted by the pituitary to other organs, to stimulate other organs as TSH or ACTH or FSH and so on. If I have absence of these hormones, I will have consequent atrophy of other endocrine organs. So endocrine atrophy occurs due to loss of hormonal stimulation by the pituitary gland. In cases of hypopituitarism, this will lead to atrophy of the other endocrine glands. We have pressure atrophy. Pressure means you have something pressing the blood supply of an organ. So you have some pressure exerted by a tumor or something like that on another organ, and this will compromise the blood supply of this organ, leading to atrophy of the organ due to the compromise of its blood supply. We have the diminished blood supply without pressure. If you have just stenosis, you have some diminished caliber of the artery going to an organ. This will lead to ischemia or diminished blood supply to the organ, and this will lead to atrophy of the organ. Why? To adapt to the new blood supply. So diminished blood supply to an organ as a result of some stenosis of the artery supplying this organ, or some pressure exerted by another organ or something on this organ. So I have in both diminished blood supply leading to atrophy of that organ. At last, we have inadequate nutrition, as in cases of marasmus. Marasmus is a form of hyponutrition leading to marked atrophy of the different muscles in the body. So inadequate nutrition, whether it is just protein, inadequate protein nutrition, or total inadequate nutrition, اللي هو أمراض سوء التغذية. This will lead to atrophy. And all these are pathological causes of atrophy: disuse, neuropathic, endocrine, pressure, diminished blood supply, or inadequate nutrition, as in cases of marasmus. If you look for examples, look at this. This is the example we have seen in the match question before. This is atrophy of this limb as a result of poliomyelitis. And what kind of atrophy is it? Physiologic or pathologic? Of course, it is pathologic. What is the cause? The cause is neuropathic due to loss of the nerve supply to this muscle. So you have, this is the normal muscle. Look at the size of the fibers here, and this is the atrophic muscle. Look at the size of the fibers. So you have diminished in the size of the fibers, leading to diminished in the size of the muscle, and you may have also diminished in number of the muscles. Look at this. This is a specimen from our museum. This is a vertebral column, and this is the aorta. So you have aorta and you have vertebral column. If you look at the vertebral column, you have the vertebral bodies and you have the intervertebral disc. This is the disc. This is the aorta, and it has a pathology. This aorta here is tubal. Okay, in these two areas, it is ballooned. You have a balloon. This balloon is called aneurysm. So you have aneurysmal dilatation of the aorta leading to this balloon like that, here and here. This will lead to pressure exerted by this balloon. Okay, this is pressure like that, pressure like that exerted by this balloon. And so this aneurysmal dilatation of the aorta will lead to pressure. This pressure is exerted on the surrounding organs. What is the organ beneath the aorta? It is the vertebral column. Look here, you have what? You have pressure exerted on the vertebral bodies and intervertebral disc. Who is going to suffer? The vertebral bodies. Why? Because by this pressure you are going to compromise the blood flow. The intervertebral disc are avascular, and so by exerting pressure you are not going to do anything to them. So the pressure here will lead to, look at this, there is diminished in the size of these vertebral bodies, sparing the intervertebral disc, and you have this festooned appearance. This festooned appearance results from atrophy occurring in the vertebral bodies, sparing the intervertebral discs. Inside the aorta there is something, this is the thrombus, you are going to learn not now. Okay, so you have here aneurysmal dilatation of the aorta leading to pressure atrophy of some vertebral bodies, sparing the intervertebral disc, and this is a kind of pressure atrophy due to pressure exerted by this aneurysmal dilatation of the aorta. If you look at this is brown atrophy of the heart. This occurs in aging persons. Aging, and in aging this is a physiologic kind of atrophy. Look at this heart. This heart is very small. Look at the muscle, the myocardium. It is very thin, okay, very thin, and so we have atrophy of the heart. You say, okay, this heart may be heart of a child. If you look at this is the aorta, and you can find atherosclerosis اللي هو تصلب الشرايين, and this atherosclerosis occurs in all patients, aging patients. So you have aging patient here with atrophy of the heart that has a brown color, and you are going to identify what is the cause of this brown color later on in this chapter, and so you call it brown atrophy of the heart. So this is a kind of atrophy occurring in the heart. Look at this. This is a child, African child. Look at this child. You can find the ribs very apparent. Look at his limbs. You can find there is marked thinning of the upper limb here. Why? Because there is marked atrophy of the muscles, intercostal muscles and muscles of the limbs. This occurs in cases of marasmus due to inadequate protein nutrition. And so you have atrophy due to inadequate nutrition, nutritional. This is called marasmus here. The fundamental cellular changes occurring in all forms of atrophy due to different causes are identical, and these changes represent a treat by the cell to a smaller size at which survival is still possible. يعني الخلية هتصغر للحجم اللي هيخليها لسه عايشة وبس. So the cells are not dead, they are living, but they are small, so they can still live. There is a new equilibrium is achieved between the cell size and the diminished blood supply, diminished nutrition, or diminished trophic stimulation by hormone or by neuropathic or neuronal and so on. So you have a new equilibrium between the cell size and the new cause of the atrophy. Fine? So you reach a smaller size that you can live without being dead. This atrophy, the mechanism of this atrophy, I have decrease in the size, okay? So decrease in the size of the muscle will result from what? Decrease in the amount of protein inside this muscle. So I have decrease in the size due to decrease in the amount of protein. To decrease this amount of protein, I have two things. I have to stop or decrease synthesis, and I have increased in the destruction or in the damage or degradation. Okay, so I have decreased protein synthesis and increased protein degradation in the cells, resulting in total decrease in protein inside the cell. Fine. So I have decrease in amount of structural proteins and organelles. I have even the organelles, the mitochondria and so on, they are decreased. They are decreased here in the atrophic organ. And increased autophagic vacuole. What is autophagy? Autophagy means I eat my own mitochondria, all mitochondria, to gain some energy. When the lysosomes go and eat these mitochondria, this is called autophagy. When they eat them, they develop what is called autophagic vacuoles containing some remnants of these eaten mitochondria. These are called autophagic vacuoles. So I have decrease in the structural proteins and organelles and increased autophagic vacuoles inside these atrophic cells. There is a role of apoptosis, which is the cell suicide. We are going to talk about it later on in apoptosis and go back to atrophy to see what is the role of apoptosis in some cases of atrophy. Okay, so this is the mechanism of atrophy.
Hypertrophy. Hypertrophy هو عكس الاتروفي. It means excess nourishment, or it means increase in the cell size and consequently an increase in the organ size. So in hypertrophy, the main change is increase in the cell size, and this will lead to increase in the organ size. What is the mechanism of hypertrophy? It is the reverse of atrophy. It is increased amount of structural proteins and organelles within the cell, and this will come from what? Will come from increased protein synthesis and decreased protein degradation. The type of cells that can undergo hypertrophy, we have different types of cells undergoing hypertrophy. We have the muscle, okay, as the skeletal muscle. We have the smooth muscle, and we also have the cardiac muscle. In case of a smooth muscle, we have some ability to proliferate plus increase in the size, and this will lead to increase in the organ of, for example, uterus. And so the uterine enlargement results from hypertrophy of the individual smooth muscle fibers plus increase in their size. But in case of skeletal muscles and cardiac muscles, I have only increase in the size because they have no ability to proliferate. They can't proliferate, and so they just increase in the size. So the type of cells, we have the permanent cells and even the stable cells. The causes of hypertrophy comes from mechanical triggers, as in stretch, as in cases of athlete, or in case of stretch of the muscles due to some exercise or something like that, mechanical trigger. And we have trophic triggers by hormones, mediators, and growth factors, such in case of gravid uterus or pregnant uterus. The types of hypertrophy may be physiological and pathological. Also, we have physiological types and we have pathological types. Physiological stimuli, as in case of exercise, as increased metabolic demands and exercise, as in athlete. And if you look at the normal skeletal muscle fiber here and look at the hypertrophic skeletal muscle fiber, you can find that there is increase in the size of individual fibers, resulting increase in the size of the total muscle. If you look at this is another cause of physiological hypertrophy, in which the pregnant uterus or gravid uterus undergoes enlargement of the size due to increase in the size of the individual fibers, smooth muscle fibers. But in pregnancy, we have also increase in the number of the fibers as a result of hormonal and growth factor stimulation. Pathological stimuli of hypertrophy, as in cases of hypertension, which is increase in the blood pressure, اللي هو الضغط العالي, or reduced aortic valve outflow. You know that the aorta is the outflow of the left ventricle, and if you have reduced aortic valve outflow due to any problem in the aortic valve itself, this will lead to back pressure on the left ventricle. If you look at this, is the transverse section in the heart. You have the right ventricle and the left ventricle. Normally, you have the left ventricle, of course, is thicker than the right ventricle, but you have here the normal thickness, and this is the normal lumen. In case of hypertrophy of the heart due to hypertension, increased blood pressure inside the aorta, or some abnormality of the aortic valve leading to reduced aortic valve outflow, I have back pressure in the left ventricle, and so the left ventricle will exert more contractile pressure, leading to increase in the thickness of the muscle here. Look at the wall of the left ventricle. It will be markedly hypertrophic, and the lumen is diminished. So this is a pathologic form of hypertrophy occurring in the heart due to hypertension or reduced outflow of the aortic valve. Okay, and now we have a simple match question. Okay, hypertensive heart, tennis player, marasmus, gravid uterus, thymus in adults. Okay. Hypertensive heart represents what? This is hypertrophy, yes. Physiologic or pathologic? Of course, it is pathologic hypertrophy, in which there is increase in the size of individual cells in response to which kind of stimuli? Pathologic stimuli. Okay, so what you choose is E. Okay. It's not physiologic hypertrophy, it is pathologic hypertrophy, so the only match here is increase in the size of individual cells in response to pathologic stimuli. Very good. Tennis player, of course, tennis player is physiologic kind of hypertrophy, so it is A. Marasmus, Okay, it is not physiologic atrophy, it is pathologic atrophy. And in pathologic atrophy, you have decrease in protein synthesis and in response to pathologic stimuli. So it is B here. Fine. Okay, pregnant uterus. Pregnant uterus, hypertrophy and hyperplasia occurring together. Very good. Thymus in adults. Yeah. It is a physiologic form of atrophy. So occurring in lymphoid organs, physiologic atrophy. It is J. Fine? Very good. Hyperplasia. In hyperplasia, there is increase in the size of an organ due to increase in the number of the cells in an organ or tissue. So it is hypergenesis or increase in the cell synthesis or cell formation. So you have here, if I have an organ formed of, for example, this number of cells, I have increase in the number of cells, like that, leading to increase in the size of the organ. You may have associated increase in the size also of the individual cells, as in case of gravid uterus, or not. What's the type of cells that can undergo hyperplasia? We have three types of cells regarding their ability to proliferate. We have the labile cells that can proliferate all the time, as in case of epithelium, in case of bone marrow cells, and so on. We have the stable cells as liver and endocrine cells, smooth muscles, fibroblasts. They can proliferate on demand. Okay, they are not proliferating all the time, just proliferate on demand. And you have permanent cells that they cannot proliferate, as cardiac muscle cells, brain cells, skeletal muscle cells, very limited proliferative capacity. And so we have these kinds of cells, permanent, labile, stable. In labile cells and stable cells, they can proliferate, and so they can undergo hyperplasia. Okay, In permanent cells, they cannot proliferate. So the only adaptation that can be occurring in permanent cells, if I need more increase in the size of the organ, is only hypertrophy. Labile cells and stable cells can undergo hyperplasia and even hypertrophy in addition. Hyperplasia can be physiologic and can be pathologic. Physiological hyperplasia can be hormonal or compensatory. Hormonal hyperplasia means that I have increased hormone, and this will lead to stimulation of proliferation of the organ, as in cases of breast and uterus during pregnancy. Okay, and in the uterus I have also associated hypertrophy. So in breast and uterus I have hyperplasia occurring during pregnancy due to hormones. Okay, this hormonal stimulation, and this is physiologic, of course. I have something called compensatory hyperplasia, and this compensatory hyperplasia occurs to compensate something, as in case of liver transplantation. Of course, you know that transplantation of an organ means that you take part or whole organ and put it in another patient, from a donor to a recipient. Okay? In case of kidney, for example, you don't take part of the kidney, you take the kidney as a whole, because the kidney cannot compensate itself. So in case of transplantation, in case of kidney or heart, you take the whole kidney or the whole heart. In cases of liver, you take what? You take just part of the donor's liver and put it in the recipient, and after a while you go back to the donor, you find a total liver, and you go back to the recipient and you find a total liver. And so this part that you took from the donor, just a lobe, you put it, transplant it in a recipient, and then under the effect of polypeptide growth factors, there will be stimulation of proliferation of the hepatocytes in both, leading to regaining normal liver size in both. So this is a kind of physiologic compensatory hyperplasia in response to growth factor polypeptide stimulation. After the liver attains the normal size, there will be turn off for these growth factors, and I don't have overgrowth anymore. Fine, so this is the physiological hyperplasia occurring as a compensation to absent liver or absent part of the liver, as in cases of liver transplantation occurring in both donor and in recipient. We have pathological hyperplasia, of course, and we have a lung. In pathological forms of hyperplasia, I have some hormonal stimulation occurring that can lead to hyperplasia. Look at this simple diagram. You know that we have a pituitary gland, and we have other glands like the thyroid gland present the front of the neck, thyroid gland. Okay? You know that the pituitary gland releases TSH, thyroid stimulating hormone, to stimulate the thyroid gland to release what? To release T3 and T4. And when they reach normal level in the blood, they go and inhibit the TSH release from pituitary gland. Formation of T3 and T4 depends on iodine that comes from the soil in different vegetables and so on. Okay, so I need iodine to form T3 and T4. And this is the normal homeostasis. Pituitary gland releases TSH, then stimulates the thyroid to release T3 and T4. When they reach the normal level in the blood, they inhibit the inhibition of pituitary, and so I have no TSH anymore. It's not released, or very small amounts. Okay. If I have a problem in some regions in which the soil has diminished iodine, I have diminished iodine going through food to these persons, and so there is diminished secretion of formation of T3 and T4, especially during their demand, during pregnancy, puberty, and so on. So I need T3 and T4. If I have diminished iodine, so T3 and T4 will be below normal. They will be released, but there will be below normal level in the blood.
This will lead to some release of the inhibitory effect here, and so this inhibition is released. Pituitary gland starts to release TSH. So I have increased TSH. Why? To go to stimulate the thyroid gland, okay, to release more T3 and T4. This will lead to proliferation of the thyroid gland, okay, acini, and so the acini will increase in the number, and the gland will start to form nodules due to different bouts of stimulation. So the gland will be enlarged like that, and it will form nodules like that. Okay, so I have enlargement of the thyroid gland due to increase in the number of acini lining the thyroid follicles like that. Why? Because they want to secrete more and more T3 and T4. So I have hyperplasia, increase in the number of acini, number of the lining cells. This will lead to increase in the size of the thyroid gland, to increase the formation of T3 and T4 until we reach their normal level in the blood, to stop the pituitary gland from releasing more TSH. Okay, this will lead to this enlargement of the thyroid gland. This thyroid gland is present here in the front of the neck, and this enlargement is not tumorous, non-neoplastic. This is called goiter. So the non-neoplastic enlargement of the thyroid gland is called goiter. Okay, and this goiter is nodular because we have a lot of nodules are formed during different bouts of stimulation. So I have nodularity of the thyroid gland like that. These are the nodules seen in growth. And at the same time, it is simple because T3 and T4 are not increased beyond the normal level. They are increased until they reach the normal level. So it's called simple. If they are above the normal level, this is called toxic. This is another issue. But in this case, they are simple. And they result from the stimulation of thyroid gland by TSH released from pituitary gland. If you look at the microscopic level, you have increase in the number of acini of the thyroid gland. You have increase in the number of the acini and in the number of the lining cells, and you have increase in the amount of colloid. This is the colloid inside. So you have increase in the amount of colloid, increase in the number of acini, increase in the number of cells lining the acini. Why? This is a form of hyperplasia occurring in the thyroid gland in response to stimulation by TSH, thyroid stimulating hormone, in some areas due to some lack of iodine in the soil. This will lead to this simple nodular goiter, and this is a form of hyperplasia in response to pathology. So this is called pathological hyperplasia. The second form of pathological hyperplasia under hormonal influence is the endometrial hyperplasia. You all know that we have the endometrium, we have the menstrual cycle, and the endometrium that lines the uterus. This is the uterus, and this is the endometrial lining here. Okay, this endometrium is under the effect of hormones during the menstrual cycle. We have in the center we have ovulation here, in the middle of the cycle. In the first half of the cycle, we have estrogen hormone, and this estrogen hormone leads to proliferation of the endometrium. So I have proliferation of the endometrium during the first half of the cycle. With ovulation, I start to have progesterone, okay, secreted from corpus luteum, and estrogen stops. And so no more proliferation, but the glands that proliferated start to acquire secretion. So I have secretion and no more proliferation during the second half of the cycle under the effect of progesterone. This until the end of the cycle, there is two ways. If pregnancy occurs, this is exaggerated. No pregnancy, so there is menstruation, shedding of this endometrium. Fine. And so the endometrium normally is under the effect of estrogen in the first half of the cycle only until ovulation occurs, and then this proliferation stops and progesterone starts to have secretory component inside these endometrial glands. What happens if I have unopposed estrogen? What do you mean by unopposed estrogen? I have, for example, a follicular cyst in the ovary that secretes estrogen all the time. And so this endometrium will be under the effect of estrogen only. And so you don't have this part. Okay, you can just erase this part. No ovulation, no progesterone. Okay, nothing like that. So what I have here in the second half of the cycle, I have more and more proliferation under the effect of estrogen again. Okay, more and more until the endometrium is very thick, okay, like that. And when it is very thick like that, it starts shedding, leading to endometrial bleeding. Okay, this increase in the endometrium is related to increase in the number of the endometrial glands, in the number of the lining cells of the endometrial glands, so it is hyperplasia. So I have endometrial hyperplasia in cases of unopposed estrogen, no progesterone. So it increases proliferation until the end of the cycle, and there is no menstruation, there is irregular bleeding by this, and this is the endometrial hyperplasia. Take care that endometrial hyperplasia is not a very friendly lesion. This lesion is pre-malignant, and so it can turn to malignancy, endometrial carcinoma later on. So this lesion is in particular a pre-malignant one. This can lead to carcinoma later on. Fine. So this is the case of endometrial hyperplasia. And again, this is a pathological form of hyperplasia, and it is under the effect of hormone, which is estrogen. Okay. Third lesion here, we have, as we talked about the females and the endometrium, we have to talk about males. Okay? Not only females are affected by hyperplasia, but also males are affected by hyperplasia. What is the organ here affected in males by hyperplasia? It is the prostate. And the prostate is under hormonal effect. What happens in old age in males? They don't have menopause, but they have some hormonal imbalance in old age. This hormonal imbalance will lead to the proliferation of the prostatic glands. So I have the prostate. Okay, you all know the prostate. It has in the center it has the prostatic urethra, and we have the two prostatic glands like that. This is one and this is one, and there are others. These are two lateral prostatic glands. They have the prostatic acini like that, and they have their ducts that go and put the secretions through the prostatic urethra. So we have, these are the prostatic acini, and they are surrounded by the fibromuscular stroma, smooth muscles, to help in they contract to help the expulsion of the secretion from these prostatic acini. So I have fibromuscular stroma surrounding these prostatic acini. What happens in old age? In old age, I have some hormonal imbalance, and this will affect these prostatic acini, so they will increase in number, increase in size, lining cells will increase in number, and I have secretions, a lot of secretions. This occurs in old age, so they call it benign, senile, because it occurs in old age. Okay, senile prostatic hyperplasia. Senile because it occurs in old age. Fine. This is the picture of the microscopic slide of a prostatic hyperplasia. Look at the glands. Here are the prostatic acini. These prostatic acini are increased in number. They are enlarged and they are irregular. They have this flower shape. They look like flowers. And look at the lining. Why do they look like flowers? Because look here. What is this? This is the proliferation of the lining cells forming something like called papillae. They have papillae inside. So they form these papillary projections inside. Okay, they form these papillary projections inside, and these papillary projections are formed of proliferating epithelial cells. So you have inside these papillae. Fine, so they are rounded from outside. From inside they look like a flower, and this flower is due to proliferation of the lining epithelial cells like that, forming papillary projections inside. Fine. And sometimes we have these secretions inside, and these secretions are called corpora amylaceae. These are the secretions in the middle. These are the secretions, corpora amylaceae. In between these glands proliferating with the acini. And so in benign prostatic hyperplasia, I have proliferation of both glandular element and stromal element. The stroma is formed of fibrous tissue and smooth muscles, and the acini are lined by these proliferating epithelial cells forming papillae inside and having secretions. We have multiple, too much. You can count too many glands or acini, and you can find these papillary projections present in all these acini. Fine. So this is the benign prostatic hyperplasia. Look at this. This is a gross picture from our museum. Okay, you can find urinary bladder here and a prostate here. This urinary bladder and this prostate. Look at first at the prostate. You have the two lateral prostatic glands, and you can find that they are enlarged. How can you monitor their enlargement? Look at the urethra in between. This urethra is markedly narrowed, and this leads to urinary outlet obstruction, and so these patients always suffer from urine retention. They have retention of urine. They cannot urinate. Fine. So they have urine retention اللي هو اسمه ايه؟ احتباس البول. Urine retention. So these old patients having senile prostatic hyperplasia complain of retention, urine retention. Due to this obstruction, look at the urinary bladder. This urinary bladder has some resistance, and this resistance leads to increase in the contractility of the wall of the bladder, and so the muscle layer, smooth muscle layer of the bladder wall is thick, okay, hypertrophic. And look at the mucosa here. The mucosa is not smooth, it is corrugated, and this mucosa is not smooth and corrugated because this bladder is in a state of continuous contraction. يبقى بسبب الاحتباس البول البلادر بتبقى فيها continuous contraction، وده يؤدي إلى thickening of the wall, hyperplasia of the smooth muscles، وكمان الميكوزا هنا هتبقى معرجة corrugated like that. Fine. So this is the case of benign prostatic hyperplasia, and you are going to study this lesion in the museum jars. So prostatic hyperplasia is another form of pathological hyperplasia under the effect of hormones, but fortunately, alhamdulillah, this is much better than endometrial hyperplasia. Why? Because all studies
that were performed on benign prostatic hyperplasia found that they don't turn malignant. ما بتتحولش إلى malignant. So this is not a pre-malignant lesion like the endometrial hyperplasia. Fine. وده ثبت من الدراسات الكتيرة جدا. Wound healing. Wound healing is another form of hyperplasia. What happens in wound? Wound يعني تعويرة. If I have a wound, I have what? I have skin like that, and I have skin like that, and this is a defect. So I have defect here. يبقى أنا عندي في الwound في عندي إيه؟ In the wound I have a defect. This defect in repair, you are going to learn this in repair later on. This defect will be filled with epithelium from both sides. So both sides will proliferate to cover this defect by epithelium. I have epithelium to cover this defect. Okay? What happens? I have growth factors released during wound, and this will lead to stimulation of the epithelial cells on both sides of the wound, where they proliferate to fill the wound like that. Okay, and this is a form of hyperplasia. This is overgrowth of the epithelium to cover this wound area, and because wound is pathology, الwound ده أصلا مش physiology, الwound is a pathological condition, so this is another form of pathological hyperplasia of the epithelium to cover the wound area. And this is under the effect of growth factors, not hormones this time. Last form of pathological hyperplasia with us is the chronic irritation by stones. Stones يعني إيه؟ Stones يعني حصوات. Stones can develop inside gallbladder اللي هي المرارة, and can develop inside the urinary tract, urinary ureter, urinary bladder, and so on. يبقى ممكن تبقى في الحالب أو المثانة. So these are the sites usually affected by stones. So I have stones اللي هي الحصوات تبقى موجودة في gall bladder أو موجودة تبقى في urinary bladder أو اليوريتر أو renal pelvis. Fine. So these stones, when they go, they are hard. The stones are hard, and usually they have rough surface. The hard stones and the rough surface will come in contact with the lining epithelium, leading to chronic irritation, and this will lead to ulceration of the epithelium. يفقد الابithelium يفقد, and then it again go and proliferate like that to avoid ulceration. So the epithelium in contact with the stones will undergo hyperplasia, trying to avoid this irritation, trying to avoid ulceration, and so it will become hyperplastic like that. So with chronic irritation by stones, I have epithelial hyperplasia of the lining epithelium in a gallbladder or in the urinary tract. So chronic irritation by stones can precipitate hyperplasia, and this is a pathological form of hyperplasia because stones are pathological. This is not a physiological condition. Fine. يبقى احنا اتكلمنا عن pathological hyperplasia, and we have said that pathological hyperplasia can occur due to hormones, growth factors, or chronic irritation. Hormones can occur as in thyroid stimulating hormone. This affect the thyroid gland. Estrogen that can affect the endometrium, can affect the breast too, endometrium, breast, and so on. And we have the hormones, male hormones, okay, that can lead to benign senile prostatic hyperplasia occurring in old age in males, growth factors in wound healing, chronic irritation as with the stones. Also, beside the stones, we have something called bilharziasis. You know bilharziasis? عارفين طبعا bilharziasis. and you know that بالهرزيزس بيبقى فيها ova, and these ova have spines. So in bilharziasis we have ova, and these ova have spines. You are going to learn this in parasitology. These bilharzia ova and these these bilharzia ova with these spines just go and penetrate the mucosa, okay, to pass through the mucosa. Okay, when they pass through the mucosa to reach the lumen, they just go and irritate the mucosa and can lead to hyperplasia. So chronic irritation can be by stones and can be by bilharziasis also. Okay. What is the mechanism of hyperplasia? Mechanism of hyperplasia عبارة عن إيه؟ The mechanism is the stimulation of proliferation of the resting stem cells and the cells of the organ. يبقى أنا عندي الستم cells اللي هي resting في الأورجنز المختلفة plus الأورجنز of the cells زي liver cells and so on. They can proliferate under the effect of hormone growth factors and so on. So we depend on resting stem cells and even on the cells of the organ to proliferate. So I have these are the cells that are stimulated by hormones or growth factors and so on to lead to hyperplasia. There is another issue. حد يقول ايه؟ طيب الهايبربليجيا هي tumor or not tumor? Is hyperplasia a tumor or not? tumor يعني ايه؟ tumor يعني ورم. tumor يعني ورم. So tumor means there is a mass hyperplasia versus neoplasia. hyperplasia اللي هو عبارة عن ايه؟ This is a form of adaptation, and this adaptation is reversible. What do you mean by reversible? If you remove the stimulus, you go back to normal. يبقى hyperplasia is a form of adaptation, and this adaptation is reversible. This means that you can remove the stimulus and then you go back to normal again. And hyperplasia usually affect the whole organ. So if you have a prostate, the whole prostate is affected by hyperplasia. Okay? Neoplasia is tumor formation, new growth. Neoplasia is not an adaptation. This is a tumor. Usually it is not, and if the stimulus is removed, again it is not reversible. If there is a stimulus, hormone for example or something, it doesn't go back. So if there is a stimulus for neoplasia, if it is removed, you don't go back. This is not reversible. And usually it forms a localized mass. If this is the prostate, the tumor is formed like that, a localized mass inside the prostate. Not all the prostate is enlarged. So this is the difference between hyperplasia and neoplasia. So hyperplasia is not a tumor, but you have to treat hyperplasia. Why? Because if you don't treat hyperplasia, for example, endometrial hyperplasia, you can pass into neoplasia, because sometimes hyperplasia is a fertile soil for neoplasia. If you have stimulation of the stem cells to proliferate, they can pass into a point at a certain point to neoplasia. So you have to stop hyperplasia, avoiding neoplasia in the diseases that can be pre-malignant. Okay, so this is the relation between hyperplasia and neoplasia. There is hyperplasia in sometimes a sort fertile soil for neoplasia, especially in endometrial hyperplasia, in chronic irritation like by stones. This can lead to tumor formation if you don't remove the stimulus. Okay, so if you don't remove the stimulus, hyperplasia can pass into neoplasia in some cases like endometrium and chronic irritation. Let's hold our breath here and solve this match question. You have 2 minutes to think. Okay, hypertensive heart. Do you remember hypertensive heart? Okay, this is a form of what? This is a form of hypertrophy. Which kind of hypertrophy? Yes, it is pathologic hypertrophy. Do you remember hypertrophy? It is increase in the size of the individual cells. If it is pathologic, so it is in response to pathologic stimuli. So, very good. So, hypertensive heart will match with E. Okay, a tennis player. Okay, again, this is hypertrophy, but is it pathologic or physiologic? It is physiologic hypertrophy, so this matches with A. Marasmus, very good. Marasmus is a kind of atrophy. Which kind of atrophy? Physiologic or pathologic? This is pathologic atrophy, and in pathologic atrophy, you have what? You have decrease in the size due to decrease in the individual size of the individual cells, and this is the decrease in size is due to what is the mechanism? Decreased protein synthesis, and so marasmus will go with B, matches with B, because I have decreased protein synthesis inside the individual fibers. Gravid or pregnant uterus, told you, yes, pregnant uterus is associated with the hypertrophy and hyperplasia of the smooth muscle cells of the myometrium. Okay, transplanted liver, liver المزروع. Remember, it is a kind of what? Hypertrophy, hyperplasia, atrophy, or what? Yes, this is hyperplasia. Very good. And this hyperplasia is physiologic and compensatory. So it is related to compensatory increase in the number of individual cells. Compensatory physiologic hyperplasia. Very good. Simple nodular goiter. This is the thyroid enlargement. Okay. Remember, thyroid enlargement is a kind of what? Hyperplasia. Is it physiologic or pathologic? Yes, it is pathologic hyperplasia in response to thyroid stimulating hormone. Okay. Fine. Very good. And here is your star. Last item in adaptation is the metaplasia. What is metaplasia? It is the change in form. Change in form. What do you mean by change in form? It is a reversible adaptation in which one adult cell type changes or differentiates into different mature cell type without crossing histological boundaries. What do you mean by that? You have an adult cell changes into another adult cell, mature adult cell. Okay, fine. So you have an mature adult cell changing into another mature adult cell, but without crossing histologic boundaries. You mean what? You mean that epithelium changes to epithelium, mesenchymal changes to mesenchymal. Okay, so this is the histological boundary, epithelium to epithelium, mesenchymal to mesenchymal. So I have in this the change of one kind of epithelium into another kind of epithelium, and this occurs in cases when there is chronic irritation and this type of epithelium can't cope with this irritation, so it changes to another type that can adapt to this irritation. Look at this. In simplistic terms, it is as if the original cells are not robust enough to withstand the new environment. I have a new environment, and the original cells cannot withstand this new environment. And so they change into another type that more suited to the new environment. بتتغير من النوع اللي هي موجودة فيه لنوع تاني يتحمل الانفايرمنت اللي موجودة دي. يبقى الخلايا مش قادرة تستحمل الانفايرمنت اللي هي فيها، فبتتحول لنوع تاني من شبيهة ليها، يعني من ابيثيليوم زيها تاني لكن نوع يتحمل الانفايرمنت الجديدة. Okay. If the stimulus that caused metaplasia is removed or ceases يتوقف, tissues return to their normal pattern of differentiation. لو رجعنا شلنا الستيمولس هنرجع تاني للنورمال differentiation. ده حاجة مهمة جدا. It is often a response to chronic irritation to withstand stress. يبقى هي دايما بسبب الكرونيك irritation. تمام. وبالتالي it doesn't occur due to any physiologic condition and so it is always pathologic. وده الاختلاف بتاع الميتابليجيا عن 3 أنواع الادابتيشن اللي فاتوا. So metaplasia is different from the 3 forms of adaptation that we have said before: atrophy, hypertrophy, hyperplasia, because all these 3 kinds have physiologic and pathologic causes. But metaplasia is always pathologic because it is a response to chronic irritation. We don't have a physiologic chronic irritation. This metaplasia may be epithelial, squamous, or columnar by genetic reprogramming of epithelial stem cells. What do you mean by that? We mean that in the embryo you have a mother stem cell, and this mother stem cell is the germ cell that can proliferate and differentiate to give all kinds of tissues. يبقى المother stem cell دي can proliferate and differentiate to give all kinds of cells. تدي كل أنواع الcells. These mother stem cells give daughter stem cells. Okay, they send daughter stem cells. These daughter stem cells go to form other organs. So we have daughter stem cells, they go to the skin. We have stem cells go to the urinary bladder. We have those that go to columnar epithelium, forming columnar epithelium lining glands in the respiratory or GIT and so on. Okay, and how does this occur? The mother stem cell has a general code, and this general code of differentiation ليها general code كبير قوي, can differentiate into all forms. When it sends daughter stem cells, each of them has a code, a certain code, and this code is responsible for the differentiation of this mother stem cell into skin, squamous, stratified squamous epithelium. Fine. So the daughter stem cell going to skin has a code to form this stratified squamous epithelium. The daughter stem cell that goes to the urinary bladder has a code to form the transitional epithelium. Okay, it is different from the stratified squamous epithelium. And the daughter stem cells going to respiratory or GIT has a code to form the columnar epithelial cells, or the pseudostratified columnar epithelium present in the respiratory tract. So it has this code. But each of these stem cells, okay, it is a stem cell. We have a stem cell everywhere. In metaplasia, what happens? I have chronic irritation of any epithelium. For example, this respiratory epithelium is chronically irritated by smoking, for example, مدخن, and this is the lining of the bronchi, and I have this pseudostratified columnar ciliated epithelium with the stem cells inside. By this chronic irritation, these stem cells can change their code. We have a change in code. It is a very complex process, but it is simply a change in the code. I have pre-programming of the code, and so I change the code to transform into another form. So I take the code of the skin. Okay, I take the code of squamous epithelium, stratified squamous epithelium. So I change the code from columnar epithelium, pseudostratified, to the code of stratified squamous epithelium, and so the stem cells here will proliferate to form stratified squamous epithelium like that of the skin. in the urinary bladder. If I have chronic irritation by bilharziasis or by stones or by whatever, and this irritation causes hyperplasia, but it is not enough to stop the process, and so I can change the code of these stem cells from forming this transitional epithelium into the code of stratified squamous epithelium with keratin. I need keratin here to prevent this chronic irritation. So I change the code from this transitional epithelium to stratified squamous epithelium. Okay. So what I do is actually the reprogramming of the genetic code of these epithelial stem cells resting in each organ, and this genetic reprogramming will lead to differentiation of these epithelial stem cells into another form of epithelium. Fine. This is the process or the mechanism of the epithelial metaplasia. So in epithelial mechanism, the mechanism here is the genetic reprogramming of the epithelium stem cells to form another form of epithelium that is suited more to the new environment present in the around the affected cells. Okay, so this is the epithelium. What is meant by squamous or columnar? Squamous or columnar is the name of the epithelial metaplasia, and we usually name by the new epithelium. If I change to squamous, this is called squamous metaplasia. If I change to columnar, this is called columnar metaplasia. So the epithelial metaplasia may be squamous metaplasia or columnar metaplasia depending on the new epithelium or the metaplastic epithelium. And the mechanism is the genetic reprogramming of the epithelial stem cells. Or we may have mesenchymal metaplasia. This mesenchymal metaplasia can be osseous, bony, or cartilaginous. So any kind of mesenchyme, fibrous tissue, fat, muscle, so on can change to bone or can change to cartilage. How? Again, you have genetic reprogramming of undifferentiated mesenchymal stem cell. So we here change the code of the mesenchymal stem cells so they differentiate to another form of mesenchymal cells. Usually they differentiate into smooth muscle, skeletal muscle, fat, cartilage, and so on. And so I can change all these to bone or cartilage. Okay, so we change the code so we can just differentiate into bone or cartilage. Fine. Usually mesenchymal metaplasia occurs due to reactive processes. We have some kind of damage, trauma, inflammation, and so on. This can lead to reactive change to osseous or cartilaginous metaplasia. But epithelial metaplasia is usually related to irritation of the epithelial cells. The epithelial metaplasia is very important because new tissue may be less specialized, leading to infection. Okay, so the new tissue may be less specialized, leading to infection. If I have this ciliated stratified pseudostratified squamous epithelium present in the respiratory tract, I have these cilia, and these cilia move. They move the mucus over them to be expelled by the respiratory tract. If I change to stratified squamous epithelium, I'm going to lose this cilia, no more cilia, and so the mucus material cannot be expelled. And so the new epithelium is more tough or stronger, fine, but it is less specialized, and this will lead to collection of mucus material inside the respiratory tract, leading to obstruction, and this will lead to bacterial overgrowth and infection. And so this is one of the complications of epithelial metaplasia, is the less specialized new tissue leading to infection. The other problem that the epithelial metaplasia can predispose to malignant change. Why? Because we did genetic reprogramming of the epithelial stem cells. This genetic reprogramming, okay, can change to have some mutation in these stem cells, and this mutation in the genes can lead to malignancy. And so actually metaplasia is not a very nice adaptation. It is not a very good or nice adaptation. It can lead to infection and can predispose to malignant change. So what do we have to do? We have to stop epithelial metaplasia by removing the stimulus, okay, to avoid infection and malignant change. Fine, because if we remove the stimulus, it can go back to normal because it is reversible. But if malignancy develops, okay, it is not reversible anymore. Look at examples for metaplasia. We have here an example for epithelial metaplasia. If you look at this diagram above, you have here basement membrane, and you have the normal columnar epithelial cells, and here the reserve cells or the stem cells, okay, stem cells. If we have chronic irritation of the columnar epithelial cells by smoking, for example, these stem cells present here will have change in their genetic code, and then they differentiate into this stratified squamous epithelium, okay. And so this is the metaplasia that develops from columnar into squamous, so it is named by the new epithelium, it is named squamous metaplasia. And this occurs in bronchi due to chronic irritation by cigarette smoke. Smoking cigarettes will lead to the change of the normal ciliated columnar mucus secreting epithelial cells into squamous epithelium, and this is called the squamous metaplasia. Of course, this can lead to infection and can lead to malignant change as a complication. Another form of metaplasia occurs in the esophagus. Remember that the esophagus is lined by what? It is lined by stratified squamous epithelium. Okay, so this is a tough epithelium. Why does it change? It changes due to chronic irritation by acid, stomach, HCl. Okay, so if I have regurg, look at this, you have the esophagus and you have the stomach here, and you have the gastroesophageal junction here. The stomach has HCl and has pepsin, you know that. But the gastric epithelium has mucus secretion, so it can cope with the HCl and pepsin. It always protects itself by the mucus secretion. The esophagus has this stratified squamous epithelium. Stratified squamous epithelium is tough, but it doesn't have mucus. And so if I have regurg of the acid inside the lower end of the esophagus, I'll have a lot of acid eroding this epithelium here. And this is called the reflux esophagitis. In cases of this chronic irritation, this epithelium in the lower end of the esophagus will change from stratified squamous epithelium into this mucus secreting epithelium, either of the gastric type or even of the intestinal type. So I have change of this epithelium in the lower esophagus into columnar secreting epithelium of gastric type or even of the intestinal type with goblet cells. So in esophagus, if I have chronic irritation of the stratified squamous epithelium by stomach HCl due to regurg of the stomach HCl, this will lead to columnar metaplasia, change to columnar epithelium. In gastric or intestinal, both have mucus secreting cells. Okay, and this was originally described by a professor named Barrett, and so they called this metaplasia Barrett's metaplasia or Barrett's esophagus. So Barrett's esophagus is the columnar metaplasia of the lower end of the esophagus in cases of chronic reflux esophagitis. In cases of reflux esophagitis. Okay, other examples, bilharziasis of the urinary bladder. In bilharziasis of the urinary bladder, we have changed from the transitional epithelium into squamous epithelium or even columnar epithelium. We have changed to squamous or even columnar epithelium, and you are going to study this in bilharziasis later on of the urinary bladder. If you look at this view shows the lower end of the esophagus, and this is the normal stratified squamous epithelium basal layer, multiple layers like that, and you have these are the squamous epithelial cells. Look at this you have these are the squamous epithelial cells, and beneath them you have what? You have glands here. You have glands, and these glands are lined by columnar cells, and they have what? They have these goblet cells. And so I have these columnar cells with a lot of goblet cells to secrete mucin. These goblet cells are characteristic of intestinal epithelium, and so I have change of the esophageal epithelium from stratified squamous epithelium into columnar epithelial cells of the intestinal type containing a lot of goblet cells to secrete mucin, and this helps to diminish the effect of acid at the lower to the lower end of the esophagus. So is it good or bad? It is bad. Why is it bad? Because they can change into malignant tumor later on. So you don't just go and leave patients with Barrett's esophagus, because they can come with a malignant tumor later on due to the reprogramming of the epithelial stem cells here, and this can lead to mutation. And so you have to what? You have to treat the patient from reflux esophagitis to reverse the metaplasia. Okay? So the metaplastic transformation of the esophageal stratified squamous epithelium to mature columnar epithelium is called Barrett's metaplasia, and again this can be the intestinal or gastric epithelial type, and this is called Barrett's esophagus. This occurs due to chronic irritation in cases of reflux of acid, reflux esophagitis. It is very important because it can change to malignancy, so you have to treat reflux esophagitis and reverse Barrett's esophagus to normal. Look at this. This is a picture of femoral condyles. And look at these femoral condyles. They are covered by cartilage. Okay, they have a cartilage here. Look at this cartilage. It is glistening, bluish cartilage. Okay, look at this. This is a spleen from our museum, in our museum. Okay, this spleen is markedly enlarged, a very huge spleen, and with this enlargement it has a lot of fibrous tissue, a lot of cracks in the capsule. It has a fibrous capsule here, and this fibrous capsule, due to this enlargement, had a lot of cracks. These cracks held by extensive fibrosis, and then the fibrous tissue changed into this. Look at this. This is glistening bluish cartilage here in the capsule of the spleen. Fine. So the capsule of the spleen changes from fibrous tissue to cartilage. And this is called what? This is called cartilaginous metaplasia. This is a form of epithelial or mesenchymal metaplasia. Yes, it is a form of cartilaginous metaplasia, and it was caused by trauma to the fibrous tissue. So this is a reactive process, and it doesn't change into malignancy. So I have this cartilaginous metaplasia present in this enlarged spleen. This is called megaly because this means enlargement, splenomegaly, with cartilaginous metaplasia of the capsule of the spleen. So this is a kind of mesenchymal metaplasia. Mesenchymal metaplasia. Another form of mesenchymal metaplasia occurs in muscles due to trauma. If I have trauma to the muscle, look, this is a muscle. Okay, this is the muscle. Okay, and here you have then, this is an X-ray, and in X-ray you find the white is the only bone with calcium. Okay, looks white. Look here, you have, this is the bone, this is the femur, and this is the pelvis. Okay, the pelvis, or bony pelvis, and this is the femur. Okay, and you have something round here that has again calcium, and it looks white in the X-ray. This is the site of the muscle here. We have rectus femoris muscle. We have a lot of muscles here, but inside the muscle we have something bony here. Okay, so we have some bony structure inside the muscle. If you take a section and look at the histology, you find the muscle here, and you can find the bone here inside the muscle. What is the bone? This is a new bone formed inside the muscle due to trauma. It is called myositis. Myo means a muscle. Itis means inflammation, so it was like inflammation in the muscle, and this was precipitated into ossification or bone, so it is called Myositis Ossificans. And this is a reactive condition in which there is mesenchymal bony or osseous metaplasia. Mesenchymal bony metaplasia. So in mesenchymal metaplasia, we have cartilaginous metaplasia occurring in the spleen, splenic capsule in case of splenomegaly, very enlarged, hugely enlarged spleen. And we have the osseous metaplasia that occurs in the muscles due to trauma. Looks like a bony mass inside the muscle, and this is called myositis ossificans. Ossificans means ossification or bone formation, and this is a reactive mesenchymal metaplasia, myositis ossificans. Let's solve this match question. Barrett's esophagus, bilharziasis of urinary bladder. Okay, in Barrett's esophagus, you have change of what? Change columnar metaplasia of squamous epithelium, or change of transitional to squamous epithelium, or change of columnar to squamous epithelium. The esophagus is lined by stratified squamous epithelium. It changes to columnar, so it is columnar metaplasia of squamous epithelium. Very good. Bilharziasis of urinary bladder. What is the original epithelium here? Transitional epithelium. It can change to squamous epithelium. This is another squamous metaplasia, so this is columnar metaplasia, and this is squamous metaplasia. Fine? Very good. In summary, pathology is the science of study of diseases. Aspects of pathology include what? What do you learn about each disease? You learn etiology, pathogenesis, mechanism, pathological features, gross and microscopic features, clinical manifestations, complications, and fate of the disease. Exposure of cells to injurious stimuli results in adaptation, reversible injury, or irreversible injury, or cell death. Adaptive responses are reversible, include atrophy, hypertrophy, hyperplasia, and metaplasia. Atrophy, hypertrophy, hyperplasia may be physiologic or pathologic. Metaplasia is always pathologic. Thank you very much.